Good morning, everyone. I'm Kimberly Chalia with PHCA. Thanks so much for joining us for today's webinar. A few quick updates to share before we get started. This webinar is being recorded and will be made available on the PHCA website. The webinar has been approved for one continuing ed credit for all attendees. For those who provided a NAB number, credits will be uploaded within the next couple of weeks. As we begin today, all attendees will be in listen-only mode. Please feel free to submit any questions that you have during today's session using the chat button at the bottom of your screen, and we'll make sure to answer as many of those questions as possible. Now I'll turn it over to Cheryl.
Good morning, and thanks so much, Kim, for the introduction, and to our Healthcare Association for having me. And yes, I say our because I am a Pennsylvania nurse, and so I know some of us have gotten some snow this morning. So, welcome to November 1st, although I don't mind it this time of year. I start minding it about mid-January. But with that being said, we'll jump right in today and we'll get started because with infection control, there's always so much to go over. During today's presentation, I really want to cover with you all how technology, such as live data analytics, can support your surveillance efforts and automate metrics and identify areas for improvement processes. When I think back to 25 years ago, 20 years ago, what infection control nurses did and what it looked like then, it was going through charts day after day after day, digging through paper charts and having multiple binders out. And now how great is it that we have technology to help us? So we're going to talk about all of that in a few moments. But as I go through it today, I think one of the things that I want to pose to you all is ask yourself some questions. Where are you getting some of this information from, and how is it being entered into your electronic medical record? But we'll get our hands dirty with that a little bit more. We'll also highlight how the use of live data and our care providers can see early identification of signs and symptoms of infection. And that's huge for all of us. And with that, then once we can wrap our head around what are our infections looking like, our healthcare associated infections, we'll get a really good understanding of our antibiotic stewardship efforts and our requirements that we need to have. With that, we can then learn those tactics to improve our antibiotic use and decrease that antibiotic resistance and avoid unnecessary adverse drug interactions. And then lastly, hopefully, I'll be able to explain how live data analytics can automate some of those efforts and reduce those overall cases. I think everybody needs to remember here too that our antibiotic stewardship efforts, it's a national call. We have serious threats now related to our antibiotic resistance, and it's really become a national priority. So there's a lot to consider, as well as, it is part of those phase 3 requirements, back that we all were made aware of back in 2016. New in infection control and kind of what do we need to review and be aware of. So with that being said, Kim, I just have a message that my internet is unstable. So please let me know if I'm having any issues if you're not seeing my screen. But with that,
Cheryl, I'm able to see it. You did break up just for a moment, but everything's working as it should.
Perfect. Okay. Thank you so much. Perfect. Thanks. So with that, I think one of the first things that I wanted to make sure I shared with everybody is that toolkit for preparing for our fall and winter virus season. If you've not heard, we're looking at a triple threat. We have potential for influenza, COVID-19, and RSV, especially when we think about our elderly population. So there's a lot to consider there. And vaccinations is one of the things that we can do to really help reduce that use of antibiotic therapy for our respiratory infections. Yes, we all know that those 3 viruses that I mentioned are viruses and that we wouldn't normally be treating them with antibiotics or antimicrobials. However, if those viruses develop into lower respiratory infections, that's when we're looking then at some of that long-term antibiotic therapy. There's some updates with our COVID-19 vaccine. So I did give you the what you need to know because we do have a new VIS for that. We also have a new VRS for our RSV. I did not put your influenza VIS here because it's not new. They are still using the same one from last year. Now, if you're not at all familiar with what I'm talking about, reach out to me after. You can shoot me an email. You'll have my contact information, and I'm happy to send you the resources for that. Additionally, I wanted to point out, and I think that everybody's probably aware of it to some degree, but it's very complicated to think about what is that new change that everybody's talking about that came out for 2024, that new fiscal year, the new role, and so much of it is related to the MDS. We have that new MDS. But also with our value-based purchasing. That's a whole other hour if you were going to spend on the impact of value-based purchasing. But let's just put it this way simply. So in your care compare, which is where all of us can go, including our residents, our families, our customers, they can see what does our facility do or look like when we talk about those quality measures or even some of those quality reporting areas. And that includes your HAIs. So CMS started collecting that data in October of 2022, of those residents that developed a healthcare associated infection in our facilities and then went out to the hospital. Now what they're going to do is take that information, and that is now going to impact our value-based purchasing starting that fiscal year of 2026. Fiscal year, by the way, is the last quarter of the year before, so it'll start in October of 2025, just to kind of keep that in mind. So what we're doing now with our HAIs and hopefully avoiding those hospitalizations with those folks, that's going to impact what that value-based purchasing look like. And if you're not familiar with that, basically what it is kind of how CMS is going to award us or reimburse us for the care that we are providing to our residents. Infection control deficiencies remain among the top 3. We'll get to look at that in a few moments. Please keep in mind that we do have that updated revised state operations manual as of February. So you want to make sure that you are working through the right one. And then with that also, don't dismiss or don't lose sight of the CDC. You have a great infection control plan outlined for long-term care facilities. I've also given you Pennsylvania's, which is that link there. So you want to make sure that you're really going through our Pennsylvania long-term care plan plan for your infection control. Also make sure that you keep updating your C. diff resources and your policies and procedures. Super significant here. C. diff continues to be a common cause of acute diarrhea in our nursing homes. We know that it can definitely be that bacterial spread easily from one resident to another, and also even the contamination of our caregivers as well. It's still something that cannot be completely killed on surfaces, so be mindful of that. And just know what the symptoms are. Know how to look at it. Know how to put your residents on contact precautions. And while we're not going to spend a ton of time on C. diff, what I will say today, again, go in there, grab onto all of the resources that the CDC is providing for you. And anytime that you have C. diff in your facility, I recommend that number 1, you talk about it in huddles with your team. If you don't know what that is, we'll dive into that in a little bit. But then number 2, do mini-in services every single time it happens in the building. Everybody needs to know how to manage C. diff in the facility. By the way, in case you're not familiar, yes, it is Clostridioids. They have updated us from Clostridium difficile to Clostridioids. And then there's also some enhancement enforcement for infection control in CMS as well. And then we have that revision history. So if you're not familiar with the CMS site where we kind of get all of our survey processes, I've given you the link there. I do want to let you know that our entrance conference form was just updated this month. So you want to make sure that you're grabbing onto that in case that is something that you did not capture, as well as we have multiple changes in critical element pathways. And we'll dive into that in a few moments, and we'll really talk about the nitty-gritty there. A lot of the changes are related to Section G because we know that that's coming out of the MDS or has come out of the MDS. And so some of the things are just updated to capture GG. But with that being said, I do want you to make sure that you have your critical element pathway for infection control and your UTIs. Infection control and UTIs had some significant changes back in June. So just make sure that you grab onto those in case you're not familiar with them. And then I want to make sure that we talk about that toolkit that I mentioned again. If we can work toward controlling some of those viruses and preventing the spread of infection in the facility, we can potentially reduce the risk of using that antibiotic therapy. By not using our antibiotic therapy unnecessarily, there's a lot of things, a lot of positive outcomes that we can have that we'll get into. So this is just a great place. You have the link for it that I just shared with you above, but I wanted you to see it. It's kind of been updated. It's newer for this flu season. And again, that triple threat that we are facing. So I wanted to make sure that everybody had that. And in case you're not familiar with what a VIS is, it's what CDC shares back with us that's called what you need to know. And so part of our requirement when we're doing our vaccinations with our resident is that we provide the education to the resident and or their families and responsible parties related to that vaccination. And there's a lot of information that they need to know, along with getting everybody to understand why it's significant and important to get that vaccine. We want to be able to talk with them about any adverse effects, not only from the vaccination itself, but let's talk about what are the signs and symptoms of influenza, RSV, and COVID? What are the adverse effects that can happen? Let's talk about what we, might be seeing with the dehydration in our kidneys, or all of those different complications, such as respiratory infections and our pneumonias. So a lot of things to consider. And then part of the requirement is that you're providing this VIS to your, again, resident and or family member before you are giving them that vaccination. So just to be aware, again, if it's something you're not familiar with, I always like to make sure that I share that. And then I'm going to pause here for a minute, and we're going to really talk about the chain of infections. If you do not have an example of a chain of infection in your facility and posting it for your team members, your residents, and your families, this is a great one. I have a lot of people that ask for this particular one, and we're actually going to go through it. As I go through, I'm going to point out a couple of areas, but again, think about your facility practices with some of these things. Think about what are you teaching your team members? Because we know that we have mandatory education in our state of Pennsylvania. Part of that is infection control. So is this a part of it? Does your team understand the chain, and do they realize that we need to break the chain to be able to improve? So if we look at the susceptible host, we know that it's a person who is potentially vulnerable to an infection, and that's every single one of our residents. Our portal of entry is the site through which a pathogen can enter the susceptible host and cause infection, such as urinary catheter or our central lines. And then we have our mode of transportation, the method or route that an organism transfers from a reservoir to a susceptible host, and can be directly by touch or aerosolized droplets, or indirectly by contact with contaminated surfaces or intermediate vectors. So I'm going to stop there for a second, and I want you to think about some of the things that we might be taking in and out of the resident rooms. Mechanical lifts is one of them right off the bat that many of us don't think about. And especially when you think about your stand and pivots, or your stand and spin, and however, your Vera lifts, your residents are holding on to them when we're using those. And so number one, are we washing our resident hands before and after we're using them? Are we disinfecting our lifts? And chances are many of us are going to say, either I'm not really sure, or B, no, we're probably not. So that's one thing right off the bat that we're taking in and out of multiple resident rooms, and potentially even in and out of multiple areas within the facility that might be a cause for a spread of infection or that mode of transportation. Think about your medication and treatment nurses also. They're in and out of the rooms with vital sign equipment all the time. Are they disinfecting that vital sign equipment? And we know that they need to be. We know that it's part of our infection control practices when we're doing those medication pass competencies. So it's one more thing that we want to make sure that we're considering and thinking about. Your medication treatment nurses, they're going in and out to potentially see what, maybe 30 people a day, possibly, right? So they're using a lot of that vital sign equipment, and we want to be mindful of that. Think too about your IV pumps and your IV poles, your tube feeding pumps, your tube feeding poles, and all of those equipments that can go from one room to another. Your infectious agent, well, that one's pretty easy, right? It's that pathogenic disease-causing microbes such as our bacteria, our parasites, our viruses, or our fungi. And then our reservoirs are the host or habitats such as humans, animals, or environment where infectious agents live and reproduce. And then we have that portal of exit, which is the route that our infectious agents leave the reservoir. And that can be either via the nose or the mouth, the urinary tract, or blood and other bodily fluids. And so again, our challenge here is to make sure that we break that chain. You know, when we think about why do we need antibiotic stewardship, and we look at some of the statistics here, it's really outstanding. Antibiotics continue to be the most frequently prescribed medications in nursing homes, with up to 70% of residents in our nursing homes receiving one or more course of systemic antibiotics once they're followed over a year. So that's a lot. Similar to the findings in hospitals, studies are also showing that 40 to 75% of antibiotics prescribed in the nursing homes may be inappropriate or unnecessary. And so think about that. We have more than 15,000 nursing homes in our country. And if we think about now all of those residents and that heavy use of our antibiotics, and all of those that are receiving them, and then possibly at least half of them not even needing them. So that's a lot. And that's why we really have a national priority here, really wrapping our heads around our antibiotic stewardship. And think about where it kind of came from. You know, many years of overuse or abuse of our antibiotic therapy, oftentimes using antibiotics when we had viruses, or many years of people using antibiotics for only short term and not fully killing our bacteria. And that's how we've had now that development of our multi-drug resistant organisms. VRE is a perfect example of why we need our antibiotic stewardship here. If we think about it, we have an estimated over 55,000 cases of VRE in our hospitals. 5,000 of those or better are the cause for deaths from our VRE infections. And then it's well over $500 million that it's costing healthcare just from that one multi-drug resistant alone. So there's so much to consider here when we think about our organisms that are those NDROs and our superbugs. And don't forget, C. diff is really considered to be one of them. So it's just another example of why do we need to have our antibiotic stewardship efforts in place. And one of the things that we can definitely do is to help control the development of our healthcare associated infections. Look, at the end of the day, our processes and our programs are very complicated and cumbersome with all that we need to share. We need to be able to prove our surveillance. We need to be able to provide all of the documentation of everything that we're doing, everything that we've done, all of the process improvement measures that we put into place. And we'll talk about those. But the consideration here is that when we can make our very best efforts and have positive outcomes in reducing our infections, in particularly our healthcare associated infections, everything else will fall into place. It stands to reason that if we reduce our infections, we reduce our HAIs, we're going to automatically reduce that need for our antibiotic use and be able to get our team in line with our antibiotic stewardship efforts. So our HAIs, they're infections that are developing in our healthcare settings. We all know that. What's significant here is, and I still can't understand why we have such a widespread, but we know that they account for 1.6 to 3.8 million infections, and over 380,000 deaths annually. So again, really high numbers here that we're talking about with the actual resident illnesses, resident deaths, and then we're looking at that cost there. They're also saying that our antimicrobial therapy is attributing to 38 million to 137 million possibly. And then we have up to $2 billion for our hospitalizations. You guessed it, catheter-associated UTIs continues to be common along with our respiratory infections. And I've spoken about that a little bit already in relation to our vaccinations. And they're potentially life-threatening for our residents. So many of our catheter-associated urinary tract infections can lead to sepsis. And we still have an estimated 7 to 10% of all long-term care residents having those urinary catheters, including 12% of all new admissions. So, whole other ball of wax there. You want to make sure when we get into our critical element pathways, if you're a building that has a lot of catheters in place, you want to make sure that you're getting that critical element pathway in place as well. This is a great site. This and AHRQ, which I do have that resource link for you at the end. If you're not familiar with AHRQ, go ahead and familiarize yourself with them. They have a lot of great tools to support us in the long-term care community when we talk about our healthcare associated infections. But here's a great spot now right within the CDC that you want to make sure that you're grabbing onto. So I wanted to make sure that I shared this one with you. And then what's new from CDC, but actually it's, when I think about it, it's not as new because it's over a year old now. I think they introduced this maybe back in last July or early August. But I know I've been speaking about it for a little while, and it's our enhanced barrier precautions. And so we're definitely going to pause here for a couple minutes, and I want you to think about them, and we're going to talk about them. I know that many of us may say, hey, you know what? CMS has not made it a federal requirement yet. And I don't know that I'm going to, do it until I see it as part of the federal requirements, but I'm going to tell you that our surveyors are looking for it, and they're going to be looking at it because it's all a part of how can we reduce the spread of infection in our facilities. And so what the CDC came out with and said is, look, we're going to recommend that you start using what's called enhanced barrier precautions. And what enhanced barrier precautions means is that when you have residents that have an infection or a colonization with an MDRO, when other precautions, other contact precautions don't apply, or they have wounds, or they have indwelling medical devices, you're going to put them on enhanced barrier precautions. And what that means is that now you have to launch an entire education program for not only your facility staff, and it's got to be for the whole building, by the way, but you now want to make sure that you're launching another education program for your residents, their families, and their representatives and their visitors. Just like COVID, one of the things we got caught with COVID was our families, our residents, they didn't know what was going on. It was knowledge that they didn't have. And that was their biggest complaint. Look, you just need to tell us what's happening. We need to know what's going on, not only with my loved one, but how much COVID do you have in the facility? Where are we going with things? And so we developed all kinds of ways of being able to communicate. And so the CDC is even saying to us up front, look, and you've got to communicate this. So they have letters that they've already prepared for the staff. They have letters that they've already prepared for our residents and our family members. And I have a whole resource page dedicated to enhanced barrier precautions. With that being said, they also have great tools for your education too, and posters that you can go ahead and launch. But so what does it mean? So we've already identified those residents that we know that we potentially want to start our enhanced barrier precautions with. But what it means now is that all staff and residents and visitors and families are going to clean their hands, including before entering and leaving the room for those folks that are on EBPs. We also want to make sure that providers and staff are wearing gloves and gowns for all high contact resident care activities. That's including dressing, bathing, transfers, linen changes, hygiene, changes in our briefs or assisting with toileting, device care for our central lines, our tube feedings, our urinary catheters, etc. and our wound care. We can never wear the same gown and gloves for care of more than one person. We all certainly know that. And that's a lot. It's a lot, number one, to make sure that we have all of the PPEs available for all of our team members to be able to do enhanced barrier precautions. But it's a lot to expect our teams that are kind of really, let's face it, a little bit thinned out and stressed many days to be able to add this in. But if you think about your enhanced barrier precautions, what it's going to do is really engage the team now to have best practices in place every day, and then those heightened practices in place for some of those residents that don't necessarily need to be otherwise on precautions. If I think back, maybe going, let's see, I'm going to say maybe going back about 20 years. If I go back, we'll think about consideration of, we used to, and I got caught doing this. I had a resident who I really thought had C. difficile. I was waiting for results to come back, and I put the resident on precautions because I thought that was the right thing to do. Well, guess what? The Department of Health came in for a survey. I got a deficiency, not for infection control. I got a deficiency because they considered it a dignity issue for the resident to have been placed on contact precautions when there was not yet a known infection. So think about now how this has come full circle, that we're kind of getting a green light. Like, okay, you have that suspected infection, you have colonizations, you have MDROs. Yes, it's okay to go ahead and place, excuse me, your residents on precautions, because now we can go ahead and put those additional efforts in to make sure that we're reducing the risk of the spread of infection. So think of it kind of as that green light. The other thing that I'll point out too is that if you've not yet put your enhanced barrier precautions in place in your facility, and this is one of the other questions that I get asked often is, where do I even start? Just pick one thing. So maybe you have a lot of Foley catheters in the facility, or maybe you are a respiratory care facility and you have a lot of trachs. Start with your trach unit. Start with your residents that have those tracheostomies, or do your tube feedings, or maybe you have a lot of wounds. Consider your facility assessment here when you're picking and choosing what area you're going to start. And as you implement anything in your infection prevention and control programs, make sure you have it laid out. Make sure you have that documentation. And remember, your IPs are part of your QAPI committee. And so these are things and programs that you want to bring past QAPI as well. So with all of that so far, where do we actually now begin to strengthen our programs, which is what we're really here to talk about today? And so right off the bat, we all need to start with our regulatory requirements. That's where it all comes from. Remember, we have to look at our federal requirements, and we have to look at our Pennsylvania state requirements as well, because we do have specific requirements related to infection control. So we want to be mindful of all of those. And then we're going to go ahead and we're going to bring that to our policies and our procedures. We'll talk about policies and procedures in a moment, because there are a couple of specific things that you need to be mindful of. Now you're going to take it to your surveillance systems. And one of the things that I want to share with you is that nobody can tell you how you have to do your surveillance, but we are going to be able to share today what are some of those things you need to make sure you are capturing with your surveillance. And hopefully that made sense. Now, data analysis. So what does that mean? Well, we got all this stuff. We captured a lot of things in our surveillance. What are you going to do with it? What is it telling you? And then based on what's it telling you, what are your provisions for improvement? If we look at our regulations, now we're looking at our infection control 880. That's our big bucket where the majority of our infection control regulations lie. That used to be, well, it was never called 880, but we used to only have one regulation for infection control. And then we started adding those back in our 2017 ROP. And then additionally, obviously with our pandemic, we had some of those additional regulations pulled back in. I have an asterisk next to infection control for the entire year so far. It has been the number 3 deficiency given across the country. So kind of keep that in mind. And our reporting 884 related to COVID-19 has been number one. So we've got a lot of work to still do. And I'm going to tell you, our surveyors are still hot and heavy going to be looking at, definitely looking at our infection prevention and control programs. And that's going to include our antibiotic stewardship. So 880, I wanted to make sure that I shared a little bit of this with you. Remember, I shared we've had a couple of changes that came into play back in, we had the new state operations manual that was released in February with some of those updates that are back in October of 2022. So be mindful of that. 880 also defines those HAIs, and we just talked about that. We talked about why it's so significant and important to understand them and help to prevent the development of our healthcare associated infections or nosocomial. And then next, the one we're going to focus on is going to be that 881, and that's our antibiotic stewardship program. And I know we've talked about it a little bit, but remember, it includes that antibiotic use protocols and a system to monitor our antibiotic use. And then we have our intent there, and it's that we develop and implement the protocols to optimize the treatment of our infections. We reduce the risk of adverse events, and we're going to talk about that in a little bit. And then also, have we developed and promoted and implemented a facility-wide system to monitor the use of the antibiotics? And I think facility-wide is going to be the key there when we'll talk about some of the education for our team members. Critical element pathways. So if you're not familiar with these, this is that link that I had for you up above with CMS. If you're not familiar with these, they are phenomenal. It is the best thing that CMS gives us, and it's the best insight that we can have, to be able to wrap our heads around the regulations. Let's face it, the state operations manual is not an easy read. I recommend that each and every one of our IPs have all of their regulations for infection control in a separate binder, and kind of go ahead and put your Post-its on it, your tabs, however you want, but you need to know the regs inside and out, but they're not easy. And that's where your critical element pathways are going to come into place. This is giving you an insight as to what are our surveyors looking at when they walk into the facility. So it's helping you be prepared ahead of time. It's helping you to know what the expectations are. And this is the only place where it actually kind of guides us of what should we be looking at? How are we kind of pulling things together a little bit? And again, it's just that overall preparation. Now, when we talk about infection control, what I will tell you is you don't want to only single out this particular critical element pathway. I mentioned earlier that we have one just for UTIs, but you're also going to look at your bowel and bladder management. You want to look at your ADL care. You want to look at your respiratory care. Make sure that you look at your kitchen, your dining services, and that list kind of goes on and on when we talk about the critical element pathways, because infection control is addressed in just so many of them. If we look at our policies and procedures, so a couple of things I want to mention here. First and foremost, make sure that your policies and procedures make sense for your facility. Some of us have standard policies and procedures, and there's some great ones out there that are written ahead of time for us, and then we can adopt them, which is fine. But you want to make sure that it matches what you are capable of and what you are currently doing in your facility. You do not want policies and procedures that make no sense for your building. And think about this too. We talk about our oversight preparedness. When our surveyors come in, if they see something that looks askew, the first thing they're going to say is, can I have your policy and procedure on? Boom. If you give it to them and it doesn't make sense with what we're currently doing, or it makes no sense for the layout of our building, then they're going to, right off the bat, you're almost automatically going to get the deficiency there because you don't even have a policy and procedure to match that requirement or match what you're able to do. Additionally, with your policies and procedures, what I will point out and remind you of is that they have to be evaluated at least annually. That is going to include your infection prevention and control policies and procedures, including your antibiotic stewardship. And you want to make sure that that is being signed off by our DONs, our IPs, Our administrators, our medical directors, like I said, at a minimum once a year, you want to make sure that you're showing that you are reviewing them. Yes, they still make sense. These are the updates that we've done. If you've done any updates, you're going to make sure that you note those revision dates at the bottom of a policy and procedure. And then what's significant with our P&Ps for infection control is they actually need to be in their own binder on each unit and in each department. So they can't be locked up in the IP's office. And when I talk about the IP, yes, you need to have an IP in the state of Pennsylvania. He or she cannot also be the director of nursing. So just kind of keep that in mind. They have to, at a minimum, be a part-time employee. That is based on your facility assessment. You've got a large building and you have a high volume rate of infections. You're going to make sure that you have an IP that's full-time. And I know it's a lot with our staffing requirements to have that in place, but it's something that's going to be worth our value, and make sure that we do go ahead and do that. But getting back to your policies and procedures, they need to be in a separate binder, and your teams need to know where they are. If a surveyor asks a team member on the unit, do you know where your infection control policies and procedures are? They need to be able to go behind the desk, and they need to be able to pull that binder right out and say, yes, this is where we keep them. So that's just one thing that I want you to keep in mind. And I mentioned our infection preventionist. I'm not going to spend tons of time on this, just to kind of review where does their role fit in? And well, right off the bat, they're the sheriff, for our infection prevention and control. And that's going to go ahead and include our antibiotic stewardship. And they need to be the person who can identify evidence-based guidelines to inform our facility of specific guidelines for initiating antibiotics and treating infections. That person has to be strong too, because we want them to be able to communicate with our physicians, our medical director, and even our residents and their families. They're going to be the one that's really pushing to educate the staff, the residents, and the families during the implementation of our antibiotic policies and our stewardship requirements, conducting that process surveillance to monitor the antibiotic use and assess adherence to the antibiotic prescribing and using those policies. And then that outcome surveillance is going to be a huge part of what our IP is doing. What are the roles of our antimicrobials? And I know you're probably thinking, Cheryl, come on, this is basic. I learned this in nursing school. But there's always something that is, reminds us of things that we don't quite think about. So we want to look at things sometimes a little more simply and just even look at them a little more differently. But the IP has to understand the role of the antibiotics and other antimicrobials, because we're not just talking about antibiotics. In a moment, we'll talk about our antifungals and how we can really get ourselves in trouble with our antifungals. But we know it's a common class of antibiotics and how they vary in spectrum of activity. There's differences between prophylactic, empiric, and therapeutic use of our antimicrobials. And there's also a need for us to understand the relationship between antimicrobial use and the emergence of resistance, and then also the strategies to optimize the treatment of bacterial infections while reducing harms and adverse events from those drugs. And then again, that's our antibiotic stewardship. If you're not familiar with this, the CDC has really laid it out for us and really guides us into our 7 core elements of our antibiotic stewardship. And so I am actually going to take a few minutes and we're going to kind of go over them a little bit, just to give you a little bit of guidance and kind of a leg up on what we're looking at and what we're thinking about. So your leadership commitment, who is that and who does that include? Well, that's going to be our medical director, our clinical nurse leads. So yes, our DON, yes, our infection preventionists, but I also want you to think about your unit managers and your supervisors and incorporating them into this as well. You're also going to make sure that you have your consultant pharmacist as part of your antibiotic stewardship program. When we consider then how they work together, a huge part of that is going to be in really creating that culture. So, if you think about your medical director, he or she is going to be the person who's going to really kind of pull together all of your other physicians that are coming into the building and saying, look, this is what the facility is going to start doing. This is how we're working with our antibiotic stewardship program. And I need everybody to kind of get on board and work with the facility on this. So that's just one example of kind of creating that culture and how we want to go ahead and do all of this and pull that education together. Then we have our accountability. And so this really is more about support. It's not about pointing the finger. It's not about blaming, but it's really about how can each of us support the other, and how can we support our nurses that are on the units? How can we assist the nurses that are speaking to our families and our physicians and our residents about antibiotics? You know, how can we make sure we're empowering our director of nursing and our infection preventionists to be able to assist them in having these successful programs and being able to work through the process? Same thing with our consultant pharmacists, our medical director. Now I want you to think too about your lab. How are we working with our consultant laboratory? You know, when we think about our antibiotic stewardship efforts, are they the ones that are assisting us in having our antibiogram, you know, another component of our stewardship programs? And then even think about to your pharmacy. What are they sharing with you every month so that you know what antibiotics have been ordered, or excuse me, antimicrobials were ordered during the month? What is the duration of the days for your residents? Where do we have that accountability from each of our partners? And then don't forget too, we have our state and local health departments that can assist us with our efforts in infection prevention and control. When we look at the drug expertise, I mean, a little bit of this one is kind of a little more simple, but so yes, our consultant pharmacist, I mean, you know, he or she is going to be it here to help us with that expertise. And really, they need to have access to everything that we can give them to support our antibiotic stewardship efforts and to be able to help them assist us. And they're part of your surveillance as well here. But also now your antibiotic stewardship training, when we think about that drug expertise. With your antibiotic stewardship, you want to be able to have it all laid out in your policies and procedures, as well as you need to have a defined location, and it can be through technology, by the way, but you need to have a defined location of where your nurses can access antibiotic information. So just kind of keep that in mind. And then also that physician communication. It's huge with developing our relationships there. When we think about the action, this one's not as complicated as it needs to be, because really we're thinking about implementing our prescribing policies. So we've kind of already done that when we made the determination to be certain we had that antibiotic stewardship program. So we want to make sure that we're looking at those policies, meeting the requirements, but yet able to meet what we're doing within the facility. And then how do we kind of evaluate and manage that? And that's going to be, again, where part of we have now our pharmacy interventions, our, you know, our consultant pharmacist and our physicians as well. And then if we look at the last three, we have our tracking, reporting, and education. So if we think about our tracking first, well, this is where a lot of that surveillance is going to come into place. And so what we really need to consider here now is, how are we measuring or managing our antibiotic usage? And we have to have an outcome process here, a measure outcome process. And that can be what the CDC is guiding us as one of 3 metrics that we're using. And I'm going to dive into those metrics in just a few moments when we talk about how technology can help them with it. And then again, when we find those breaches in our stewardship programs, you know, what did your surveillance tell you? What were you looking at? And that's where it's going to fall into the reporting, because now we're going to report those. We want to be able to find those areas that need that improvement. We want to be able to communicate that. But don't forget here too, I want to make sure that you understand it's also great and insignificant to report those positive outcomes. We want to be able to show those things we did well. We want to be able to show those things that we've been able to improve upon. But we still want to make sure that we're putting those process measures in place for those areas that do need that improvement. And we want to ultimately our goal here is to be sure that we're improving our resident outcomes. And then the last part of that is going to be our education. And I think what's significant with education is we really need to break our old beliefs, right? We know that we have so many residents and family members that they had poor histories with how they took that antibiotic use. And they always wanted to go on an antibiotic every time they had the littlest thing. Some of them wanted to be on those antibiotics, take them for 3 days and then stop. And again, that's part of how we had the development of our multi-drug resistant organisms. So that's where our challenges are, but it's just a lot of persistency and consistency with breaking those old beliefs. And so we also have 4 key strategies of how we can do that. And just this kind of wraps up what some of those core elements are telling us. And the first one is measuring that antibiotic use. So we'll break down in, again, just a few moments of what some of those measures can look like. But this is where you're going to have those evaluations and that documentation. Do you use standard assessments? I think that's one of the questions that you need to be able to look at. How does your team communicate to you that you have a resident who has signs and symptoms of an infection and has now been placed on an antibiotic? Who's the first person that finds that out other than that nurse and that physician and maybe that resident and their family? Are we immediately communicating this to our IP and then allowing them to do their due diligence for looking at that infection and that antibiotic use? How are we establishing the communication with our residents and our families and our physicians and our healthcare providers? And again, that IP, it's really significant that we make sure we're only using our antibiotics for those known infections that can be treated with those antimicrobials or antibiotics or antivirals. Are we using the right thing at the right time? And that's where our 5 Ds are really going to come into place. And I'll talk to you in a moment about the 4 moments. But with your 5 Ds, we have to be certain that we have the right diagnosis with the correct drug, the right dose, the right duration. And then is there an opportunity or a need for de-escalation when we think about that? And then also ensure prompt initiation of the right antibiotics when they are needed. One of the things that cannot happen here is that we have a resident who has an identified infection. They've now had an antibiotic ordered, and then we're seeing that we're documenting for the next 12, 15, 18 hours, not given, not available from pharmacy. So part of your policies and procedures should be that, what is your pharmacy emergency supply? Where is it? Who has access to it? Who's working with our pharmacy to make sure that we have A through Z of our antibiotics and antimicrobials that are available to us so that we don't have a delay in the initiation of our antibiotic therapy as it comes in. And that's something that we really need to be mindful of. Who's auditing that also? Think about that. So the IP should be looking at that. Part of your surveillance is looking at the administration of those antibiotic orders. Think about it too, what are the timing of those? If we have an antibiotic that's most effective if we give it every 12 hours, but we're giving it at, let's say, 9 a.m. in the morning, and then we have it scheduled again for 4 p.m., is that really going to be the most effective way that we can give that antimicrobial? And then also too, we're going to consider some of those adverse effects. And so the 4 moments is another way to go ahead and look at our antibiotic usage. And this I actually was able to pull from the AHRQ, and it's a little bit newer. So if it's something that you're not familiar with, we're actually going to go through them. And so moment 1, okay, it's going to pull together kind of one of those, that first key strategy. And does the resident have symptoms that suggest an infection? And here's where now you're going to look at whatever criteria you have for the defined infection, whether you're looking at McGeer or Loeb or whatever your practice is or your policies and procedures are stating. How are you truly identifying that it is an actual infection? And then what are we relaying and sharing back to our physicians and our advanced practice clinicians? And then moment 2 is, okay, now what type of infection is it? Have we collected any appropriate cultures, if that's appropriate, again, before starting those antibiotics? And what empiric therapy should be initiated, if any? What is the duration of the antibiotic therapy that's needed for the resident's diagnosis? And then moment 4, it's now been 2 to 3 days since we started antibiotics. Go ahead and reevaluate the resident, review results of diagnostic tests, and now you're going to speak with your physicians and your advanced practice clinicians and ask, can we stop those antibiotics? Can we maybe narrow that therapy? Or if we were on IV antibiotics, can we go ahead and transition that to oral? So just another way of kind of looking at, what is that de-escalation, what that can look like. And so meeting your requirements, I really wanted to do this because I thought it would be helpful to just kind of break down before we look at how technology is supporting us, what is it that we actually need? Because I've thrown so much out there of what does antibiotic stewardship mean and what can it look like, but what are some of the details of what we need? Well, we need to capture all antimicrobial usage. And so we want to make sure that we're identifying those symptoms ahead of time and then looking at those 5 Ds or the 4 moments. We want to be certain that we're measuring our antibiotic usage, and that can be from any one of our 3 metrics, such as our point prevalence, our days of therapy, or our antibiotic starts. Also, do we have our antibiograms? And I mentioned earlier, hopefully your laboratory is assisting you with your antibiograms. If they're not, ask them. I bet you they can. Also think about, are you paying attention with your consultant pharmacist to your antibiotic orders by class? Is your consultant pharmacist part of your program? And then again, what are your laboratory services? If you even think about now, we have that new development of the MDRO of our C. auris. Well, C. auris has very specific criteria of how the lab can identify that. And we need to make sure that our lab is actually able to capture. It's something that we're now seeing a higher prevalence in our long-term care facilities. So think about that as well. And then what are your prescribing practices? Are we doing those prescribing profiles with our physicians and our advanced practice clinicians? And I'll show you what that can look like in just a few moments. So what is surveillance? Well, surveillance is that ongoing and systematic collection or analysis and interpretation and dissemination of data. Well, it's a lot, but what it means is that we've really got to have our eyes on every single component of our infection prevention and control programs, as well as our antibiotic stewardship efforts. And it is the core activity, truly. What does comprehensive surveillance mean? Well, now we're going to take the entire population and we're going to look at everything a little bit differently. So here's where we're going to pool together. What do we have happening in the facility as an overall group? But then remember, we want to make sure that we're looking at our individual residents as well. And that's where some of your components in your electronic medical record can now help you. How does your team identify signs or symptoms of infections? And I touched on this a little bit earlier, but here's some great tools that can support you. How are they reporting those signs and symptoms of infections? And who, what, how, and why, and when are we communicating to the infection preventionist? And does everybody even understand our policies and procedures and our stewardship efforts? So even your stop and watch tool from Interact is a great tool that we can go ahead and have our CNAs use to communicate to our nurses. What might they be seeing with our residents? I've even seen facilities where environmental services uses these as well. And then are we looking at any of our care pathways for symptoms of any of our infections, and identifying those symptoms and be able to walk through that pathway. So it's just an opportunity here to be able to think about what are you using, and then how is our technology going to help pull it all together for us? And so think about this. Your technology is going to develop that consistent and complete data collection process. It's going to facilitate the data summary and analysis and calculations of your surveillance rates, save time with our programs and our central monitoring systems, identify and isolate those trends, easily demonstrate through use of charts and graphs the types of infections and location of infections, and then also monitor the required components of our stewardship programs. And so this is just another example of kind of pulling together how we want to make sure we're looking at some of those components. So identifying that early onset of our signs and symptoms of infectious processes, making sure that we're mapping and locating our infections. That is a crucial part of our surveillance. implementing measures to prevent the spread of infection, track and trend all of our infections, including our outbreaks, establishing daily antibiotic surveillance, simplify our reporting process, and also supporting our physicians with those metrics. And so I mentioned earlier that active surveillance and what that can look like. So we have to have at least one metric that we are using for measuring our antibiotic usage. You want to go ahead and reevaluate that metric at a minimum once a year. And so if you establish a baseline, whichever metric you use, whether it's point prevalence, antibiotic starts, or days of therapy, you're going to establish that baseline and try to improve that goal every single year. You don't have to reach far. You don't have to go from, we had, maybe 26% of our residents receiving antibiotics on an average of a month, and I want to now get that down to 16. Give yourself a more realistic goal. Yes, we can put all of these measures in place. And if we can go from 26 to 16, that's just gosh darn awesome. But let's maybe go from 26 to 22 or 26 to 20. You don't have to go ahead and overreach. Remember that point prevalence is going to give you that snapshot. I really like point prevalence a lot to be able to give me the snapshot of what are my percentages looking like month over month for that 12-month period. Pull that information together and set it that way. Or you can do those antibiotic starts and that days of therapy. When you're looking at your infections and your antibiotics here, remember you have to establish that tracking. Part of our requirement is that we have a map of our facility. That map can be however it lays it out for you so that you can quickly visually see when you have a problem with the spread of infection. You can quickly identify outbreaks. You can quickly identify, hey, I have an E. coli UTI happening in room 101. I have an E. coli UTI happening in room 102, and I have the same thing across the hall. I think I need to look at hand washing. I think I need to look at pericare, whatever it may be, but you need to make sure that you have that in place. And when you find those breaches, that's when you're going to get your hands dirty, do that root cause analysis, and then have that process improvement plan in place. And remember, you're going to be part of QAPI as well. Same thing and same concept with your HAIs, but now you want to break that down a little bit differently. I want to make sure I know where in the facility is my highest prevalence of my healthcare associated infections. So again, I can put some of those process improvement measures in place. I talked about prescribing profiles, and this is something that not everybody's familiar with, but at a minimum, once a quarter, you have to share back to your physicians and your advanced practice clinicians, what are their antimicrobial prescribing practices looking like? So that's something you want to be mindful of. AHRQ gives us a great example of that. Think about how is your technology assisting you? What can your electronic medical record give that to you? But so part of your antimicrobial and antibiotic use tracking is going to be by physician or by practitioner, and then you've got to share those practices back with them. And when you see any of those breaches in their practices, you want to make sure you share it. I won't spend a ton of time on this one, but I always like to point out with everyone that with our infections come increased risk in so many ways. Number one thing is to make sure that we're looking at our adverse drug effects. We want to be certain that we have those improved patient outcomes and that we're avoiding any declines because of those. Move beyond your basics now. Okay, how many times have we realized that a resident has a UTI or a respiratory infection and the next morning we come in and they've had a fall? So kind of think about how can we go outside of the box here and look at a couple of additional pieces. Provisions for improvement. Remember that you are part of our QAPI program and that you have to bring some of this information back to back to your QAPI and be certain that you're putting those provisions for improvement in place. And there's just a little bit of a layout there. And then I have lots of resources that are available to you all. Please go ahead and grab onto them. I know I had some of your vaccine resources in the beginning as well. And if you want to be able to grab your influenza, which I usually have an influenza resource page in here at this time of the year, and I realized this morning that I did not. So make sure that you go ahead and go to the CDC to grab that. But then I also wanted to point out on this page, I do have the DOH antibiotic stewardship in nursing homes, and for some reason it is not going to the right place. But if you just go ahead and Google Pennsylvania DOH antibiotic stewardship in nursing homes, you'll be able to see it, and you can grab onto it, because you do want to be able to keep up with our Pennsylvania components as well. Make sure that you get your core elements for your antibiotic stewardship, and I recommend doing the checklist for the core elements as well, so that you can grab onto that. And Kim, with that being said, did I see that we might have a couple of questions that have come in?
It was me, Cheryl. I was putting reminders in throughout your session, just to remind all attendees to submit questions as we went along. We didn't have any questions presented at this time, but as always, feel free to reach out to myself or Cheryl if you feel more comfortable emailing a question after the session. That is a-okay. We're here to help. And Cheryl, thanks so much for your time today. This was a great session.
Great. Thanks so much, Kim, and have a great day, everyone.
Thanks.